Optimal health for high performers. This is the Health Upgrade Podcast with Dr. Nawaz Habib.
Hello, everybody. Welcome back to the Health Upgrade Podcast. I'm here with JP. How are you, sir?
Doing really well. Thank you.
Wonderful. And we have a wonderful guest today, and I'm very excited about this topic because we don't talk about pelvic floor as much as I would like us to. And we have a wonderful guest, Dr. Anna Sierra, with us today. How are you?
I'm very nice. I'm very happy to be here. Really excited about beginning this.
Wonderful. So we're honored to have you here. It was a connection that was made by our mutual friend, Dr. Jolene Brighton, one of your best friends, I believe. And she has mentioned many times in our conversations how important her relationship with you and how much she's learned from having you on her podcast as well. She was a guest recently on ours. And she said, you need to talk to Dr. Anna because what we're going to be able to learn is a little bit more about that autonomic connection to pelvic floor functionality. You are a endometriosis and neuropelveology surgeon. Tell us a little bit about what got you into that area and how you became interested in these particular areas.
Okay, I think chronic pelvic pain patients are like one of the biggest challenges that we face as gynecologists. It's like that patient that goes from one doctor to another doctor to another doctor and nobody finds the reason that they have pain. So it was really frustrating to me. And I started looking for answers. And I started doing several courses in different places. And I was in a bus in Barretos in Brazil. And one of the doctors was telling me, okay, if you love so much and you're so much interested about chronic pelvic pain, why don't you study neuropelveology? And I was like, okay, tell me more. What is neuropelveology? And then I found out about Dr. Mark Posover and the ISON, the International Society of Neuropelveology. And the first quote that I got from them is, pain is not a pathology. Pain is information that travels through your nerves. So that only was like, okay, here we have some sort of answers because we're not just numbing the pain and giving them just medication in order to numb them or doing like blockages to the nerves. We're actually finding or thinking about the pain as a way to find a solution in order for our patients to be without pain. So first, that was the thing that got me into neuropelveology. I love the fact that we look for answers and we look for the places that the pain begins. We have a way of thinking, and the clinical exploration is really important for us. Also, the clinical history. And I think is one of the main things that got me into this. And endometriosis patients can benefit a lot from this because most of them have chronic pelvic pain.
So my father was a gynecologist, and he and I used to talk about the experiences that he had in his practice and with his partners with women who had endometriosis. And one of the things that he observed through 40 years of practicing medicine was that oftentimes when women complained of that pain and there was any kind of surgical exploration of the tissue, many times there was no outward sign that there was any problem. And that yet other times, as a ancillary finding in other surgeries, he would note that endometrial tissues looked inflamed or looked thickened and looked like the patient would have symptoms. And then when he queried the patient afterwards, the patient said, no pain at all. So this model of the pain arising directly from the tissues that are associated or localized where the pain is was really something that isn't true. That's not why the patient has the pain. That's not where the pain is coming from, or at least it's not the primary reason why pain is the symptom that they're experiencing. How do you reconcile that? How does the neurology of it make sense of that?
First, we need to understand that there's two types of pain. We have visceral pain and we have somatic pain. Visceral pain is the pain that our patients with endometriosis have, the one that is regulated by the vagus nerve. But we know that the symptoms that have visceral pain is that pain that does not, or they cannot pinpoint with one finger. I have pain here. It's like everywhere else. And then it has another type of symptoms that accompany them. We call them the neurovagus or neural symptoms. It can be like they feel bad. When I have my menstrual cramps, I feel like I want to faint. I'm pale. My hairs are like erected, or I feel like I'm about to vomit. All of these other types of symptoms define a visceral pain, not like the case of somatic pain that our patients can pinpoint with one finger. That is usually because nerve entrapment or one nervous fiber suffering from inflammation. And it's a very different experience. And it's not always accompanied by another types of symptoms. So first we have to understand what kind of pain is our patient feeling. And then we can try to understand which is the neural fibers that are irritated because of the pain. And also, pain is an experience. It's not just information. That's a thing that I learned like years after I did this training, because our patients do not feel the same pain when they are with their families that with they are alone, or when they have stress because of their work and where they are in a holiday. It's a different experience. So pain is so much more than just information in our neurons. No?
Absolutely. Pain is something that is a perception. And if you think about a perception, the nerves are carrying impulses. Those impulses aren't pain. The impulses are just information coming in, and the brain has to process that information to determine what the appropriate perception is. I mean, just to really sort of frame that, think of it like the TV signals that are coming in through through the cable. Those are electrical impulses. They are not video. You have to have the video processor take that information, convert it into something that you can see. Well, that's what's happening in your body. There's information coming up and information in your brain that biases how that's going to be interpreted, and then you interpret it. So it's just a fascinating process. Are there things about patients who have endometriosis, maybe life experiences or prior surgeries or prior traumas or prior illnesses that tend to characterize those patients? Because we see that with like fibromyalgia as well.
Yeah, it's a whole experience, and it's pain that has been through so many years that there's changes in their brain. Their MRI show changes in the amygdala, in the limbic center. There are a lot of changes that patients do suffer, and also the neurotransmitters. By base, the cells from endometriosis, they have like an immune response. Endometriosis is a whole body disease, we call them. It's a systemic chronic disease. So this affects the immune system that is going to fight against these cells that don't recognize and start secreting cytokines or cytokines. I don't know if it's
Cytokines, yeah.
it's okay. And then one of them is a neural growth factor. So it's going to happen that one of the neurons is going to stretch its legs and it's going to innervate directly this plaque of endometriosis. And to this, information of inflammation is going to start reaching the brain through this neuron. And as we do know, there's this capacitation and neurons that without more changes or more information and by the recollecting of time and recollecting several times through time, you become really good at something. When we try to teach our kids to speak and we show them a card and we say cat and again cat, every time we recollect this information, our brain is going to be even better to do this. So our patients with endometriosis and also fibromyalgia patients become really good at transmitting information of pain. And not only this, it's sometimes not even needed a signal or a stimulus to have pain. And once we have central sensitization, that's the most complicated part. And I think that is one of the things that vagus nerve can also help our patients.
Yeah, let's talk a little bit about central sensitization, because there's lots of different conditions that experience basically the same problems. We talked about fibromyalgia, we talked about endometriosis, there's chronic fatigue, there's a form of central sensitization that can be migraines, that can be TMJ. And a lot of times these conditions actually exist in the same person because the same mechanism is at play. Do you find that patients with endometriosis oftentimes also experience migraines, have, respiratory issues, have gastric motility problems, like, IBS symptoms. There's a whole sort of field of symptoms that go along with it. And do you find that medication is oftentimes less effective in masking those symptoms for those patients?
Yeah, first of all, symptoms, all of the above. All of the ones that you mentioned do, yes. But I think that is the most important part of it will be for the patients to understand the importance of rewiring their pelvis. When I started them on physical therapy and I start to talk about them, the importance of becoming again aware of the real signals to wanted to empty their bladder, to wanted to, in order they want to have intercourse to relax their muscles, or if they have a full a rectum to release the poop. All of this are signals that get mixed into the pain signals. So our patients usually have a pelvis that their muscles are really contracted and they no longer receive the correct information. So it's like, do I want to pee or am I in pain? And if I want to have intercourse, am I having pain because I'm having intercourse or I have my regular pain? Some of my patients have told me that it's like living in your body, having like an alien that you have to share your body with. So the most important part about this rewiring is beginning to understand where is the problem and starting to feel again the real signals from your bladder, from your pelvic floor, and from your rectum.
What are some of the common reasons why this processing of different types of information, all neural information that's coming up, become distorted? And you kind of place what used to be a normal feeling of I need to go to the bathroom to release my bladder or to defecate. And how does that get confused into a pain experience? Is there a certain pattern that you've noticed that might trigger something like that to occur?
Well, most of our patients do have prior trauma. It can be like, I don't know if you've ever read about chakras, and the pelvic chakra is usually because some former trauma in their life prior to. But what I really can tell you is that our patients do have this rewiring because of so many years with pain. So the way that the pain is transmitted is no longer a signal of afferent, efferent, and in a very regular way. It's abnormal because of the inflammation and the new nerve pathways that have formed. So the pain is no longer the regular signal. It's really increased in. So no longer sometimes doesn't have to reach the center of the brain. Or if they reach the center of the brain cannot figure out where is the pain coming because it's usually visceral pain. So your ovaries, your vagina, your uterus, your rectum, they all came innervated by the same central or the same the same nerves that get into the same like if when you are giving somebody, I don't know the word in English, but if you are running and then you give like a little stick to the next guy, how do you call that?
A baton, like a relay race.
A relay. Okay. The relay of the information usually is in the superior hypogastric plexus, that it's located on your lumbar and your sacral region. So a lot of our patients have this referral pain into their lower back because of that referral first. It's like the first relay. The word real. Thank you. And then it goes to your brain. But in order to go through your brain, through your asta dorsalis, your brain is not going longer to be able to say, oh, my ovary is hurting or my bladder is hurting. Anything is hurting.
One of the first things that I learned, so I'm a chiropractor by profession, and one of the first things I learned in chiropractic college, the first motion that we were taught actually was sacral pumping release, basically. And this was an important moment, I think, for us to understand. First off, it's a very gentle motion that is very easily learned. So chiropractors, as we're kind of going through our 4 years of school, we need to learn how to use our hands quite effectively, but you have to start gently. One of the things that they talked about was the fact that lower back pain is often triggered by a lot of inflammation or functionality that's happening in the pelvic floor area, in situations such as menstrual cramping, endometriosis, etc. and that referral of these internal issues would show up as lower back pain. But if you were to figure out where your patient was in their cycle on the female side of things, going and actually helping to release some of that pelvic floor tension is going to significantly release some of that lower back pain. You're talking very much in kind of the world that I started up in chiropractic, of referred pain and this relay race of getting these, passing the signal from one nerve to the next nerve and having this information come up, but it becoming confused in certain areas. And so it shows up in different ways, referred pain. Tell me a little bit about the innervation of kind of pelvic floor in relation to a lot of these organs that you mentioned earlier, the uterus, the vagina, et cetera, and the pelvic floor musculature. Is there something that gets confused, or is there a specific set of innervation that needs to be discussed when you're talking about the pelvic floor in particular?
I think it's both somatic and autonomic. You have to handle them both because all of those nerves are in the pelvis. We have the same amount of connection in the pelvis that we have in the brain. So we have a brain down there. And we need to understand this. There's also some theories about the same laterality as your brain. So as I'm left-handed, supposedly my dominant brain will be right. So supposedly my right pelvis will be dominant. So I hope that if somebody does a surgery on my pelvic nerves are on the left side, because I will have more neuroplasticity in order for them if I do have my dominant right side. Also, you can understand that in the superior hypogastric plexus has two main nerves that are called the hypogastric nerves. Those get together with the ventral branch of the sacral nerves that are the parasympathetic nerves, and they get together with this sympathetic branch forming the inferior hypogastric plexus. So you have both sympathetic and parasympathetic innervation. In females, it's on the back side of the uterus where the uterosacral ligaments are. So whenever you have a patient that have an increased or a thickening of the uterosacral ligaments, that really are not ligaments, they are just foldings into the fascia, but let's call them ligaments still, they're really near to these terminal branches. So if you have a patient with endometriosis, I often tell my patients that endo is like it's inflammation. It's like having a candle that it's lightened. So it radiates heat. So you don't need really to compress the nerve to start making it suffer. If you have a candle and you place a wire on top of it, the irradiated heat is going to mess with the plastic covering of the nerve. So when you lose your myelin sheath, you're going to have irregular activity of this nerve. So in our patients, especially that have problems with their uterosacral ligaments, they're going to have problems with voiding of their bladder, having problems with their pelvic floor muscles, and last but not least, problems, a lot of constipation. And all of this because of their regulation. But this regulation sometimes is like not longer even functional after a lot of time. And we have had many patients that there's an association. We cannot establish causality still, but a lot of patients do suffer also from POTS, that it's another autonomic problem. So everything is linked together. We haven't found the way that everything gets connected. I have one of my teachers told me that it's like having a cat sleeping on one of those ceilings that are made from metal that are like folded. So even though the cat sleeps in a folded floor or it's something that is depressed, it doesn't mean that the cat has folded the ceiling. It just means that they coexist at the same time in the same space. So just because we find two things in the same place doesn't mean that they are one caused by the other. They just correlate.
Yeah.
And a lot of our patients have had like POTS. We have a lot of patients with problems with mastocytes release. A lot of patients have Ehlers-Danlos or any problems with hyperflexibility or hypermobility. So there's immune system and there's some connections there, but I hope we can establish them at some point further on.
You mentioned Ehlers-Danlos, and I think that's probably where JP was going to go with this.
Yeah, we've encountered EDS as another type of trigger for fibromyalgia-like pain or visceral pain or other issues. The spectrum of different symptoms that Ehlers-Danlos patients have maps tremendously to where we've also seen vagus nerve stimulation be beneficial. So there's definitely an autonomic nervous system component to the symptoms associated with that, which is, Ehlers-Danlos is typically, either a genetic problem or some sort of connective tissue disorder that causes that structural difficulty. But I'm always fascinated by, so less what's happening down in the tissue itself, but as those signals come up into the brain, because yes, there may be altered structure of the nerves in the tissue itself, but the interpretation of the signals that are coming up is where I think we have the greatest ability to change how the patient feels. So what I mean by that is that if the patient has experienced trauma and and inflammation, and as a result of that, there's been that change in nerve connectivity in a way that's structured to bring signals more readily up to the brain that could be interpreted as pain. That doesn't necessarily mean that that is actually going to be the experience the patient has, because the patient may, in the brain, be able to recognize that that altered signaling still doesn't mean that the right interpretation should be to feel pain, because you don't feel pain in your leg or in your belly or in your arm. You feel pain in your brain. All those peripheral things are doing is sending signals. So I think of the brain as being the place where we have the greatest opportunity to change our pain state. And this is what this is why Navy SEALs and Tibetan monks can do incredible things while the rest of us would be debilitated with pain. They don't experience it because they've changed how their brain is going to interpret that signal. So when you're dealing with patients who have these conditions and you're trying to monitor or modulate how their pain experience is affecting them, what are the go-to tools that you work with, and what are the strategies? Are they peripheral? Are they local? Or are they more centrally focused, or both?
We have both, actually. We do work with psychiatrists and a psychologist that do help them with both the fact of dealing with everything that they deal, and also in terms of neuromodulation, because sometimes you have to help the brain release the pain. In peripheral, we do work with a physical therapist that do help us so much. They have shown me how do all of the pelvic floor muscles feel when we do an exploration. Because in my formation as a GYN, I just have to understand the cervix and the uterosacral ligaments, and that was it. But now I understand where the bulbocavernosus muscle is, where is the obturator internus muscle, and what can that do with the pudendal nerve. Or in case of, we do surgeries with neuromonitorization, so in order to do nerve releases. So while having a patient with neuromonitorization, I started exploring them. So if I touched here, which nerve am I irritating? So my neurophysiologist will tell me S1, S2, S3. So I understand now more the physiology and where are these nerves located. And now I can pinpoint places that have pain. The first thing that we need in diagnosis is to understand how is this pain being translated into the brain and which nerve is using, so we can help our patients. I do not like, there's some therapies that do tap nerving, that they tap a point, and wherever the patient has pain, they put lidocaine in it. I don't like this because you are not doing a diagnosis. You are just numbing the pain. So it's better if I understand, okay, this pain is originated because of compression or because, I don't know, there's a problem in your genitofemoralis nerve. Maybe I'll block it. And then that will be if you have a full relief of pain, that will be a positive test. And then we can think about Botox, or we can think about doing another surgery. The less surgeries we do on nerves is always better. We know that any scarring tissue that we can leave behind. Sometimes there's vascular compression of the nerve, or sometimes they leave something behind. For example, in patients that have tackers, that are the way that we fixate mesh, or even the mesh, or sometimes they leave staples or something that is irritating the nerve. So in these cases, we have to remove this tissue. Or endometriosis. Sometimes endo can grow outside of the nerves. It's really strange or really rare to have an intrinsic lesion, like endometriosis is growing in the nerve. I've just seen once in my life, but mostly it's because it's growing from the outside to the inside. And we can have two types of lesions in the nerve, the neurogenic and the non-neurogenic. Neurogenic lesions are the complete blockage of information, like if you cut a nerve. And non-neurogenic, that are much more common in my practice, is the one that is going through a little bit of time, or just time after time. Like, for example, adhesions. Or one of the most common causes can be like this ovarian pain that is really on the wall of the abdomen, because patients had like a C-section years ago. And one of the techniques that they use is elongate the tissue. And sometimes they elongate iliohypogastric or ilioinguinalis nerve, and they feel like their ovary is in pain. But really, it's a pain referred from the wall. So sometimes we do a lidocaine test. If it's positive, sometimes it's not. Sometimes we do have to release the nerve, and other times we just have to use Botox therapy. And as it is just a sensitive nerve, they do have a lot of release. So you have to work with the cause and then the best treatment for them.
I think the compression piece is one that is likely more common that you see. Is that true? Do you see more of the compression, more of the non-neurogenic pain rather than the actual neurogenic pain?
Yes.
Yeah. And that for me plays a huge role in looking at fascial function, and fascia kind of playing a major role there, as the nerves tend to run through fascia. But also muscular, right? And specifically, are there muscles that may be compressed or tight at certain times, secondary to potentially neurogenic reasons as to why that muscle would become tight, and the pelvic floor will follow. And I think you're focused on such an important area that is so overlooked when it comes to optimal function. The pelvic floor, I think, is this area that we tend not to give a lot of importance or focus to, yet it's where all of our toxins are generally released from through voiding bladder or through defecation. So in addition, we have sexual function that happens through this area. We have optimal mechanical function that happens through this area. When it comes to these fascial tightness or muscular tightness that can be compressing on this, are there any specific patterns or root causes that you tend to see? Any list of things that might be triggering these types of problems in the first place, the root causes?
Oh, yeah. Well, we know that the activity of the muscle is like a window to the way that the patient deals with the world. So if they encounter a world in which they have pain all of the time, they protect themselves. So they have contracturated muscles. That is the most common thing, the most common cause of the dysfunction that we see in pelvic floor. And also normalizing most of them, so it keeps going on time because they normalize the symptoms. When I ask the patient, "Oh, do you have any problem when you pee?" And they say, "No, everything is fine." Okay, when you take a seat in the toilet, do you start peeing right away? Oh, no, well, I have to wait a little bit and then the pee will start. Okay, do you have to push to finish peeing? Well, yes, obviously, always. Aha. And then how about when you are finished, do you have to pee again in less than an hour? Well, yes, but I take 1 liter of water in the whole day. That's a lot of water. Well, right, actually, no. So you're not supposed to feel that you didn't empty your bladder. So these symptoms are normalized, and then they don't seek attention at the beginning of the symptoms. And that is why it keeps going and keeps going. It keeps going through a lot of time. And could I ask you a question, Dr. Habib?
Of course.
Because I have this, because you were telling about fascia, and I've seen patients that have TMJ, temporomandibular pain. And when they treat this, the pain in the pelvis go away. Is there a connection there because of the fascia, or what happens there?
I honestly have attributed it more to autonomic functionality. rather than
Okay.
fascial functionality. Now, not to say that there
Okay.
isn't a fascial connection, because I'm sure there is,
Okay.
but it's this massive web going from TMJ down. But from an
Okay.
autonomic standpoint and from a trauma standpoint, because you mentioned trauma as an important root cause for a lot of people that are having these challenges, we tend to, as you mentioned, the pelvic chakra, we also have the throat chakra. And the throat
Okay.
chakra and the pelvic chakra, and I believe in terms of the energy flow, needs to happen
Mm-hmm.
optimally through all of the chakras. But the throat chakra tends to be one of not being able to speak your truth. And that's where the dysfunction comes from.
Okay.
And when you have TMJ type issues, often it comes physically from clenching. And
Mm-hmm.
clenching up here in your jaw area and getting your TMJ dysfunctional because you're clenching too hard one side versus the other, or you're not aware of deviations or deflection in your mandibular motion pattern, is actually the same idea as clenching below in the pelvic floor. And that clenching is where these small symptoms that you mentioned just now start to pick up. We start to notice that we're clenching because what we're doing is clenching is, like you mentioned, that's sympathetic activation, right? We tend to, when there is a stressor, when there's something that we feel is threatening to us, not necessarily towards our survival, but just threatening to our functionality, we tighten up. We tighten up our breathing muscles. We tighten up our jaw muscles. We're not eating at that time. We're clenching the throat, clenching the jaw, and we're also clenching the pelvic floor, because this isn't a great time to go to the bathroom because there's a threat to our survival. And what happens, I think, over time is it, just like a TMJ type of issue or a temporomandibular dysfunction issue becomes severe if not treated or handled early, same idea happens in the pelvic floor. And we have this confusion of somatic and autonomic signaling that, because we're in this stressed or traumatized state for such a long period of time, and that stress becomes chronic, long-standing, we're driven into this sympathetic overdrive state. And we tend to mask a lot of other areas very well. We tend to mask, the upper back. Okay, I'm tight, I'll get massage and I'll be okay, right? Or I'll go for a chiropractic adjustment and I'll be okay for a couple of months. But how you are handling stress shows up in these particular areas more severely than others. And that's things like the TMJ and it's things like the pelvic floor. So for me, I think that's huge.
There's something really interesting about this, because we know that we think of when you flex your muscle, you're doing work, but it's actually kind of the opposite, in that the relaxed state of your muscle is what it requires energy to actually relax your muscle. Your muscle wants to actually be flexed. That's why when you die, you end up flexed. And if you get paralyzed or you have some loss of signal to the muscle, you actually clench, you flex. So the interesting question is whether or not sympathetic activity is associated with clenching, and where parasympathetic is associated with relaxing. You need that parasympathetic signaling, because at the neuromuscular junction, it's acetylcholine that's being released to relax. So you want to have that parasympathetic state in order to not clench. And if you're in a chronic sympathetic state, then you're going to end up over time developing these problems. And the question for you, Dr. Sierra, is, after spending, at this point, 20 years in this space, it's become somewhat intuitive for me to recognize people who are in a chronic sympathetic state. I can just tell when you're talking to a person, when you're interacting with them, when you watch them move, you can just tell that person is more sympathetically driven, has a lower HRV, has a higher risk of inflammation, has higher, is probably experiencing the symptoms that we've talked about and more. Do you have the same ability to sort of intuit when a patient is at risk, just based on their behavior patterns, based on their speech patterns, based on just watching their facial expressions. Can you just see it in them?
Yes, our teacher tells us that you can see the pain in your patient's eyes. You can even see how their reflex, the pupil reflex, does not work the same or at the same speed as other types of patients. I didn't believe it until I started seeing it. And I have patients that have had this sympathetic response for so much time that they do have problems with the pupil, the refraction or the mydriasis and the mydriosis. And also, especially regulating temperature. We have had patients that have in one leg one temperature and the other leg does have more than 1 centigrade rate of difference between, like, it's 1 feet is colder because the sympathetic system. So there's an entrapment there and we have to solve it. So yes, I see the physical because I do the physical examination, but we can also see the way that the patient behaves. And so we have both.
It's a fascinating observation that over time you can start to just see it in people. And there's another one. I don't know if you've ever used it before because it involves the immune system, but we've talked about it a couple times on the podcast. If you take your the fingernail, and you rub it across, the back, or somewhere like the arm, somewhere where you've got a large amount of skin, and you just run your fingernail across it, not deep enough to really scratch the person, but just to give them a stimulus. For most people, there's not going to be any mark. For some people, you'll see a little red streak. But in some people, that red streak will be pronounced, and you'll actually see the skin raised, almost like an allergic response to that signal. I'm wondering whether or not you see that more frequently in the patients, and maybe you don't know, but it would be an interesting thing to detect or to study, whether or not you see that occurring with a high frequency in this patient population. Because my suspicion is that you will, that you're going to see that as sort of a very easy symptom as to whether or not they have this chronic sympathetic overdrive, this central sensitization that results from that, and the pain that they're experiencing.
Oh, dermographism, it's not like one of the symptoms that we see, but for example, pressure pain, they have done studies for endometriosis patients with pressure pain before and after the surgery. And before and after we do intervention, nutritional interventions, physical therapy, like we downregulate their sympathetic system. So the amount of pressure that patients need to have pain before and after the intervention is always a lot more in order to have pain. I mean, they have pain with a little less pressure, and after the surgery, they can take more. I mean, they're less like upregulated to feeling pain.
Yeah, you're lowering that threshold that's required to initiate the pain.
Threshold, yes.
That's so important to understand. I want to discuss, or I want you to share some of the practices that you utilize in practice to avoid going towards surgery. Yes, you mentioned earlier that you want minimal surgical intervention. At times it's necessary, but if you can minimize or push it off as long as possible, that's ideal. You mentioned pelvic floor physiotherapy or pelvic floor support. And just as a personal side note, during my wife's pregnancies, both times, symphysis pubis dysfunction was severe and she had a lot of this shearing pain. And so pelvic floor physio was an absolute game changer for us. We did some acupuncture, we did some soft tissue therapy. Lucky enough, I was well versed enough in soft tissue therapy to help with that. But this was an issue that she was dealing with through the pregnancies, just during this hyper-stressed experience, acutely and I guess chronically if you're getting up into that 9-month range. But that shearing force and that pain that she was experiencing was linked to a lack of muscle functionality and optimal muscle functionality in the pelvic floor. And the physio was very important. Talk about some of the nutritional interventions that you utilize and some of the physio style therapies that are beneficial in these situations.
I work in a multidisciplinary group, so I do not give them nutritional and I do the physical workup, but if I think that they do need physical therapy, I send them to a physical therapy experts. The way that I found my team, it's because they align with the way that I think. So if you go to any physical therapist, especially for endometriosis patients, and if I go and they tell me, oh, you have a very unstable pelvic floor, you need to do more Kegels. And that's not the problem. In patients that have a contracturated muscle, if I tell them to even strengthen their floor, all of the symptoms start to get worse. So it was really important for me to find one of these physical therapists that understand endometriosis pain and understand endometriosis patients, and also work with a downregulation of the sympathetic system. They do have, I don't know the way it's called, it's PEST. It's a special system that helps with vagus nerve, and they get stimulated for them to start improving the way that they void their bladder. That is one of the symptoms that are more commonly affected because of the uterosacral ligaments that I was explaining. The nutritional aspects of it, you have a chronic inflammation disease. So you need to don't throw more wood into the fire. So if you add inflammation because of some certain foods that do cause inflammation in certain patients, I do not make with the idea that you have to remove everything and that you have to just eat vegetables and chicken broth, because we have very malnourished patients of the way that they try to find the foods that is nourishing them. But they have to understand that it's like a trial and error start of testing that our nutritionists do in order for them to have all of the food groups without removing none of the food groups. But some patients are really sensitive to the seeds of the tomatoes. And that is something that we will never think about. Or some other patients are sensitive to gluten or to dairy or to red meats. So we have to work with every patient because everyone is different, and we can no longer make a diet that is specific for endometriosis. You have to find the way, and every patient is different.
I think it's so important to talk about personalization and work with an individual focused protocol, right? And find what works for that person and try to remove some of those inflammatory triggers and some of those inflammatory patterns. This is wonderful information. JP, what are some final questions you have here for Dr. Yanasier?
Well, I just maybe just a comment, which is I think it's fascinating. I think it's wonderful that people are starting to recognize, and you're at the forefront of this, recognizing that pain isn't necessarily caused by a specific problem at the location where the patient is experiencing it. That pain is a much more complicated process. It involves, yes, nerve signaling, sometimes prior nerve signaling. It involves what's happening in the central nervous system. It involves the relays from that tissue through the spinal cord up to the central nervous system. There are mechanisms that we have that are positives, things like descending inhibition, that allow us to, using our brains and using our central nervous system, suppress pain or pain signaling. There's also perception. We have to teach people. I think one of the things you talked about earlier was the fact that pain is different for a person who's, at home relaxed versus at work. In fact, it was a great study done that paper cuts hurt more at work than they do at home. And you think to yourself, it's the same paper cut. Why would it hurt differently? But it's because in one setting, you're comfortable. You're more sympathetic, or you're parasympathetically driven, whereas the other, you're sympathetically driven and hurts more. So if you're always in that sympathetic state, things are going to hurt more. You're going to tend to interpret the signals coming up as pain, even though in other settings you might not. So I think that the fact that you're recognizing that this, endometrial pain, visceral pain is one of a spectrum of problems that people have that are part of this pathology, and that maybe we can treat all of them simultaneously with a single set of therapies or a single set of strategies. Even though they're very different, they really aren't, because they are very much the same in their underlying structure.
I wonder, I have a bit of a follow-up question to this. What are some of the therapies from a brain retraining standpoint, from a psychology or psychiatry type of standpoint, that you and your team utilizes to help with changing that perception of not only the pain, but also helping to create that difference again of retraining to understand that, oh, this is just a feeling that I need to void my bladder versus this is actual somatic pain or visceral pain that I'm experiencing.
The physical therapist works with them in order for them to start scanning their body. This is not something that happens on the first visit. They do have to work for it in order to become again aware of their own body. Our psychologists help them to process the information, like in a way that you can always, reality is how you interpret it. So the way that they help them is to understand their reality in a non or more of dealing with and empowering them to the way that they are being able to do everything that they do and also have this disease. So this disease will no longer take full control of their lives. And our psychiatrist helps them because the way that their neurotransmitters is different. So sometimes antidepressants helps us to modulate pain. And other types of drugs or the chemicals helps us to for the brain to understand that you no longer need the pain in order to survive. So that's the thing, because your brain is helping you survive and is thinking that all of this inflammation and all of this information that it's sending is protecting you. So you need to try to hack into the brain and to tell them that it's no longer needed and you have to thank him for it and try to live forward with it. Sometimes we do nerve blockages into the superior hypogastric plexus. We don't cut it. We think that cutting a nerve removes the ability of dealing with the things, because there are presacral neurectomies that is, well, here in Mexico, it is taught as a therapy to remove chronic pelvic pain. I don't think that is a very good idea because you remove the whole sympathetic system and now you cannot deal with it. And the patients that come to me after years of this no longer can regulate the way they pee, they poop, they have sexual activity, they always have sexual intercourse, and they're always in pain. And I can no longer treat the nerve because it's hot. So I don't believe in cutting nerves, neither in burning them. There's also another therapy called the Luna therapy that is about burning all of the inferior hypogastric plexus for them to not feel the pain. But if I cut your hand, you will still feel your hand. So that's the thing that some doctors haven't understand yet about pain. And it's really hard for me because the ways that I can help these patients are very limited when they no longer have these connections. So I think giving this type of podcast and all the work that you do and helping them understand the importance of this is going to help a lot of patients, hopefully.
I think it's so important for us to stop framing pain as the problem, right? I think yes, it sucks. Like when you are in pain, it is unbearable. It is challenging. It is one of those experiences that nobody wants to go through. And I have numerous family members and loved ones around me that have experienced chronic pain, but it's not the pain that's the problem. It's trying to find out why it's being experienced as pain in the severe level that it is. And you're absolutely right. If you go and cut the nerve, you can't undo that. That is an issue that you're just stopping the symptom. You're not actually
You're not even
fixing
stopping the
why.
symptom. In some cases, you're cementing the symptom.
Yeah, even making it worse, right? Yeah.
If that's the interpretation that your brain has of that signal, and then you stop the signal, that doesn't mean that the brain is going to reset. It may just be stuck there.
Are you aware of any neuromodulation or electrotherapy type stimulation practices that can help with pelvic floor pain and endometriosis pain?
Yeah, we have InterStim and
Interesting.
helps us with regulating, S2, S3, S4 is the roots that regulate upwards, to the parasympathetic system, and they helps us with avoidance for the bladder, but also helps us with chronic pelvic pain. We also can give like a direct pump, like for patients that do have chronic pelvic pain, and it's like a pump that it's embedded in the dermis, in the flesh, in the skin. Yeah, and they have this tube that you can place directly the analgesics into the nerve that it's irritated, because sometimes the sheath is damaged or the nerve is so damaged that all you can do is numb it. So we try not to get there. And also neurostimulation. Our professor did his technique. It's the lion technique. It's about stimulating nerves for recovering the function of special nerves like the sciatic nerve, the femoral nerve. So patients that have spinal cord injuries can start moving again.
That's amazing. JP, are you aware of any research on vagus nerve stim specifically for pelvic floor issues at all?
Not directly in endometriosis, but in many other of the pain symptoms that are associated with it. Obviously, it's approved for migraines, but there's lots of other data out there looking at things like gastric motility and respiratory issues. And I believe that there is work that's been done in TMJ or TMD. So I think there's every reason to believe that it would be beneficial for people with pelvic floor pain since the same mechanisms are at play.
Yeah, I think that makes a lot of sense. I just hadn't come across any specific research, so I wanted to know if you had seen anything. One of the things that not a lot of people understand, and I just want to kind of wrap it up on a little bit of an educational note, is that there is a little bit of vagus nerve innervation to the pelvic floor, but the majority of the parasympathetic innervation to the pelvic floor comes from the sacral and coccygeal nerves specifically. There is parasympathetic innervation there. Dr. Sierra, would you mind just explaining that mechanism or the neurophysiology there of how the parasympathetics connect in the pelvic area specifically?
Well, as I was saying before, the inferior hypogastric plexus has branches for the bladder, for the pelvic floor muscles, and also for the rectum. And well, in females, for the vagina and the uterus. So all of these branches get together like in a half a circle sort of way and in a very intricate web. So we used to pull on the nerves on one side and you can see the movement on the other side and you see, oh, see, it's like a circle. Now we don't do that, of course, because if you touch the nerve, you're damaging it. So we try to never touch a nerve, but still in cadavers, you can see this, that they do move together. Everything gets together in the pelvis.
Yeah. So this is important for people to understand that, yes, there is a vagal component, but it's not directly vagus nerve innervated for the majority of the pelvic floor, especially the musculature.
The muscle, yes, but
Yeah.
in the rectum,
Yes.
up to the last third of the intestinal, it's because of the vagus nerve.
That's
So
right.
it's,
Yeah. So when
it's a lot of there.
yeah, when we get to the digestive tract, we're talking vagus nerve, but when we're getting into the muscles, then we're talking the sacral, inferior hypogastric specifically. Wonderful. That is a lot of great information. I think I've learned a lot. I think it's important for people to understand that pelvic floor pain, endometriosis pain, needs to be properly assessed and identified. A pattern has clearly arisen of some sort of trauma in the past that plays an important role in the perception of that pain and the drive towards a sympathetic overdrive rather than a parasympathetic baseline. And that is often one of the driving forces that leads to these issues. It's also important, from what you mentioned, is to note that what may be normal for you is not necessarily normal, right? What you've normalized, patterns of needing to go to the bathroom numerous times within an hour off of thinking that a liter of water is a lot, that is not accurate. We need to figure out optimal. Let's not focus on normal. Let's focus on changing that word, I think, towards optimal. Is your function optimal? Are you going to the bathroom between 1 and 3 times daily and not needing to push and not needing to work hard to release stools? Are you able to void your bladder completely and not need to go to the bathroom for another 3-4 hours at minimum, right? Are you able to go immediately without the need for kind of that push to occur or for taking a moment to allow for that to occur? So these are all important points that need to be assessed. And if you do have pelvic floor pain, I would love for you to
just to
chat
add
a little bit.
something,
Yeah,
in
please
case
go.
any women is listening to this, a sexual intercourse is not supposed to hurt. Because some of our patients are told that they are too stretched or they are too tight, and that's the reason or the cause that they have sexual pain during sexual intercourse every time. So this is not normal, or this is not optimal, as you were saying.
Yes.
Thank you.
It can be common. I imagine it's much more common than we realize, but it's certainly not normal, and it's definitely not optimal. We need to help create this shift to understand that let's work towards optimal. And as we do, we'll utilize a lot of these practices that you mentioned today to help create these amazing shifts that people can finally experience. Where can people learn more about you and follow your work a little bit more online?
Online, I'm on Instagram. My name is at DRA, the lowercase ANASIERRA.
Amazing.
But we can write it in
Doctora
case
Ana Sierra. I'll
Ana
put it in
Sierra.
there for sure. I will
Thank you so much.
definitely link that in the show notes. And I think this has been a brilliant episode showcasing a topic that is not shared enough. JP, any final thoughts?
No, I think you're absolutely right. It was a pleasure speaking with you, especially, it brought back a lot of the conversations I had with my father about this subject. So that was nice.
Yeah, this was wonderful. Dr. Sierra, thank you for joining us today, for sharing your
Thank you for
brilliance.
having me.
And for anybody who got to this point in the podcast, I think you should share this episode with 2 women who in your life are dealing with things like chronic pain, pelvic floor pain, even migraines, challenges that may not be seemingly associated. They may actually be heavily linked. Things like temporomandibular disorder and pelvic floor are heavily linked, and there are connections that we need to be able to explore openly and honestly. And if you're a practitioner out there, let's do a better job of assessing and addressing these issues and working towards optimal. Again, thank you all for joining us, and we'll catch you all on the next episode.
Thank you so much.